Welcome to Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our goal is to provide a platform where we can educate, advocate, and inspire women leaders to lift as they rise. With every episode, you'll hear from her as we showcase the perspectives, insights, and experiences of women who are leading the way in advancing women's health and empowering the next generation of women in healthcare.
Welcome to today's episode of our Women in Healthcare Leadership Series. My name is Yelena Sporopoulos, and I'm the Vice President of Education at Medscape. I have the privilege today to be joined by two amazing women, Professor Fatima Rodriguez, who is the Associate Professor at Stanford University and the Director of Preventative Cardiology. So welcome, Fatima.
Thank you so much for having me.
And also I have with us Joanne Foody, who is a preventative cardiologist herself and is currently the Chief Medical Officer at Esperion. So welcome, Joanne.
Yelena, thank you. A pleasure to be here.
I'm going to get started. A lot of the topics that we'll discuss today will really focus on key issues and challenges that women face in the healthcare industry, both when it comes to the medical setting and the medical profession, as well as the pharmaceutical industry. So I'm going to ask you both, and let's start with Fatima, because I know you're very passionate on that topic, but what started you in the field of cardiology? Was there, a personal event that happened, or what really prompted your passion for the field of cardiology?
Thank you, Jelena, for having me with my beloved mentor and friend, Dr. Joanne Foody. I'll say that my interest in cardiology is very personal. When my mother was in her early 40s, so a young woman, she was ultimately diagnosed with rheumatic heart disease. And this was after many, many years of having non-specific symptoms like tachycardia, shortness of breath, swelling, all the things that we now recognize as our symptoms of advanced heart disease. And it was really a cardiologist with a stethoscope that said, you have a tight mitral valve and you need to have urgent surgery. And that was really just transformative for me as a 13-year-old. And I was committed to becoming a clinical cardiologist at that time, but also quickly recognized all the barriers that women have in being diagnosed promptly and treated appropriately.
Yeah, and I think that's a really good point that you just made about, the treatment of women when it comes to cardiology. And we'll circle back to that in just a second. But you mentioned your great relationship with Joanne, who was also your mentor. But I wanted to take a step back and ask you, Joanne, as well. What made you passionate about cardiology? What made you become a physician?
Yeah, so much like Fatima, my why for becoming a cardiologist was my family. My grandparents who passed away of cardiac disease, aunts and uncles, all afflicted by and died from heart disease. And even for my parents who currently, fortunately they've lived a long life, but who've had their share of cardiovascular issues. And I think virtually no family remains unimpacted by heart disease. And it really is personal. And this really, coupled with my deep commitment to make a difference, to help others, led me to medicine and specifically to cardiology, specifically to preventive cardiology, in really looking at ways we could hopefully help individuals not have the burden of cardiovascular disease. And then there's maybe a small part, Yelena, as given the topic, maybe in a small way because I was told that women couldn't become cardiologists because it was too hard to balance life and maybe too challenging and taxing. And I've always liked proving people wrong. So I think that's maybe a little tiny bit of my motivation as well.
And wow, did you prove them wrong? But and it's always fascinating to me because I also myself personally, I come from a family of physicians. My mother is a pediatrician, my grandmother was a pediatrician, and both of them have faced some of the similar obstacles and challenges when they were starting in their career, especially. So, Joanne, I want to follow up on that. So, what has been your experience as a woman in the field of cardiology, perhaps starting, back when you started versus, let's say, where we are today?
So really, I have been so fortunate to have mentors who have always supported me. And whether it was in medical school, during residency, or cardiology fellowship, what was so important is that for them, they reminded me that it was about excellence first. And I never felt that I was disadvantaged as a woman. In general, I had the most supportive male mentors, in fact, because female mentors were few and far between. But, I was fortunate to have those be the likes of Eugene Brunwald, Peter Libby, and Eric Topol, all of whom I feel were incredibly supportive to women in the field. I did have a few female mentors, but really very few and far between. So I think it's having people who help set you on your path and helps you aspire to really excellence and move forward in your field. So I've been very fortunate.
And what about you, Fatima? Because I know that obviously, Joanne was an incredible mentor, to you. But then I also know you've had some amazing mentors who've been men as well. So how important it is for women to have the right mentor, and sort of what can we do as women to support other women and propel them in their career progression too?
Yeah, and I think the importance of mentorship in cardiology cannot be overstated because it really can define your career. And like you mentioned, a lot of times people are like, "You sure you want to do cardiology? You sure that's a really hard lifestyle? Do you want to have a family? Do you want?" So then having somebody like Joanne Foodie, who really seemed to do it all and do it well and do it with a smile, and just was incredibly supportive, really transformed my career. And I'll say I was very committed to becoming a clinical cardiologist for my personal reasons. But with Joanne's mentorship, I became very committed to addressing some of the research questions and to academic medicine. And it really was Joanne saying, if you get that abstract in, don't worry about the cost, we'll take care of it. If, do this and do that, and giving me all the opportunities. And she was a mentor and a sponsor. Very uniquely in a way that I felt like Joanne really cared about me as a person. And I think she still does. And there's different mentors have different roles in your career, but I think Joanne, for me, has been really transformative in pursuing this career path. And like you've said, I've had other wonderful mentors, among those Bob Harrington was our chair of medicine now at Cornell, David Marin. So very important that yes, it's men tend to be more often the mentors just because there's more men in cardiology. Really, it's a numbers issue. But I think it is important to have somebody that represents you as a woman who has similar struggles, things, especially as your life progresses and you have families and you're balancing different things that are unique to women. It's really important to have that mentorship.
Yeah, I couldn't agree more. And so to get back to what you said just a second ago, having the appropriate mentorship is definitely crucial. But I also think something you just said is very, very important, that I think when we look today and we look at those leadership roles, chairs of departments, deans of different medical schools, chief medical officers, I think when we look at the numbers, and especially in cardiology, I think the number of the ratio of men to women is still, far from where I think we all strive to be. So did you want to comment on that? And what can we really do to help women not just enter the field of cardiology, but get to those leadership roles?
Yes, and I think that there's clearly a leaky pipeline. I would say that as a medical resident at the Brigham, there were many women who wanted to go into cardiology. And throughout the medical education process, something happened that dissuaded that decision. So we start losing talent there. Then we lose talent as we go through all the training process. But really, when we look at the chairs and chiefs and CMOs, very, very few women. So what I think needs to happen is that there needs to be representation, because people tend to like people like them. And unfortunately, we see that. We need to check people's biases. Like there's been a lot of times where people may not ask me to do something because they'll say, "Oh, she has a lot going on. She has 3 young kids." So don't do things like that. I'll say that even to our male leaders. Let the women make the decision. Maybe it's not the right decision for that time. But I think, again, we have different standards for men and women, and we need to have representation to mirror our population.
And Yelena, if I can jump in, I think one of the words that Fatima used that is really critical is sponsor. We talk an awful lot about mentorship, but there is a need for individuals to sponsor those individuals, whether male or female, who can, achieve a certain, be on a certain committee or step up to a key position. So it's not just mentorship, it's really this critical role of sponsorship and ensuring that everyone is thinking broadly about those capable of being in certain roles. And to Fatima's other point, right, this issue of feeling, being aware of our own biases, right? Have we really looked expansively when we consider a position? When we'll talk more about a clinical trial, leadership within that, have we really cast a broad net? And we need to do a better job. And those of us in higher positions need to be confident that we are sponsoring.
Yeah,
people,
I think that's a really
mentoring.
important point, and certainly true of both the healthcare institutions as well as the pharmaceutical industry. And I think we talked a lot about sort of what we can do. But I wanted to get back to the topic also of discussing where the current gaps are, not just in sort of career progression in cardiology when it comes to women, but also in terms of the cardiology care that women receive, right? Fatima, you had a great example from your own personal life. But how can we address that and ensure that women get equitable care and are treated appropriately and not dismissed due to the perhaps different presentation of the cardiac symptoms, due to the fact that perhaps they communicate symptoms differently? But how can we really ensure that that's not a gap today in 2023?
I'll just comment that I think this is something that even when I worked with Joanne as a student, we looked at this and it was pervasive year after year. We see that young women are dying more often from myocardial infarctions. And a lot of this, again, is biases, what people assume somebody that comes in with a heart attack looks like. And again, we know that that's just not true, that heart disease is the #1 killer for women too. I think cardiology has a little bit of a PR problem in terms of our patients, that there's so much attention for cancer. And again, cancer is a terrible disease, but the prognosis for someone with heart disease can many times be much worse than that for cancer. So I think we need to measure it. So that's one thing, as researchers, we spend a lot of time doing, but move beyond describing the gaps and really try to develop interventions that can close that gap. One very simple thing as we think about our science is that we need to make sure our clinical trials have a population that reflects our regular population, which should be 50% women. And I'll say that I was just at a wonderful meeting where Keith Ferdinand said, we need to stop treating women like special populations. They're 50% of the population. This is the population. So I think, again, just normalizing being inclusive and studying women and making sure we have the right treatments for them.
Yeah, and Joanne, I'd love to get your feedback here too, both from your background as a cardiologist in clinical research, but both from the perspective of your role in the pharmaceutical industry, where as chief medical officer, I'm sure you have the opportunity to lead many different clinical trials.
Absolutely. So, as Fatima just mentioned, we will never, ever be able to achieve population health until we actually study therapies in all the individuals at risk, whether male, female, Black, white, or of different ethnic origins. Clinical trials really have to mirror those we care for. And currently they don't. We're making strides, but given the fact that industry funds really the lion's share of trials around innovations across healthcare, we as an organization, as industry, really need to make that commitment. Why until now have there not been equal numbers of women in cardiovascular trials? It's a little bit sad for me that, that causes applause that you have parity of a clinical trial in this day and age. This should have been something that has occurred decades ago. So we really must do better. We have to really cast aside all these excuses and look to solutions. So as Fatima mentioned, right, we have to stop describing the problem. And we really need to make a commitment, not just in words, but in actions, to have more representative enrollment. And I think industry is moving in that direction, but I think it also requires those consulting with industry, healthcare providers' patients to really demand that they are studied in equitable ways.
Yeah, and it's, fascinating because I was just reading an article just fairly recently, and there's a lot of published literature that speaks about this issue that women are still hugely unrepresented in many clinical trials, and not just cardiology, but in other areas as well. And then when you speak to healthcare professionals, physicians, and then certainly patients, many people will say, "Oh, that can't be true. We're in 2023. This can't be the problem anymore." So I completely agree with you that we have to do something, but I also think that perhaps just raising awareness and educating the healthcare community and the patients has a role here. But because we still see a lot of gaps simply around even just awareness. So, how do you think how can education help to achieve this?
That's a great question. And I was just chatting with a colleague about an American Heart Association video that I don't know if folks have seen with Elizabeth Banks as an actress who's saying, I'm just having a little heart attack. And she's going on with her whole day and she's sweating and she's having all the symptoms. And it's an American Heart Association education awareness. Again, very poignant, showing how you may dismiss all these symptoms. I'll give you an anecdote. I was just on the clinical service, and a youngish woman has been for 1 year having severe reflux every time she does any activity. Has a stress test, very positive. We take her to the cath lab, and her left anterior descending artery is occluded. She's a 50-year-old woman who for a year has been just dismissing these symptoms, right? So I think it's awareness from the patient side. And I have a lot of thoughts about how we can do that. But again, meeting people where they are, social media, combating misinformation in social media, making sure that if we have content online, it's verified, it's accurate, and it's actionable. And then from the physician side, this person was seeing a doctor for a year. Even more alarming, this person had FH, a familiar hypercholesterolemia for our audience. So this is somebody who had high cholesterol, and I was looking at her records for years, and in her notes it said, her HDL is pretty good, so we'll just keep watching. Again, a genetic condition that should have been picked up a long time ago that resulted in this premature heart disease. So the final thing I'll say is that this cannot start early enough. So we need to really move upstream. Joanne and I don't want to see these people in the hospital. We want them to prevent the events by treating their risk factors, diagnosing early.
And if I can just add, I think that we need to empower women as central and key caregivers. So women historically have been the caregivers for their families. And so if women aren't empowered with the right information, education to not only understand what their risks are, but what their family's risks are, we'll never get to, I'll say, population health. And importantly, right, women also are central to raising healthy children. So from an entire societal perspective, we need to focus more effort on ensuring that women have the right information because of that central role. And then lastly, I think education is great, but if we don't have equitable access, right? So Fatima, for whatever reason, this woman didn't feel like she could seek help perhaps, or there were barriers to her doing that, we'll never really ensure that people can achieve health. So again, education is a start, but we also have to educate people how they access the healthcare system and what that means to ensure that they get really that guideline-directed evidence-based care.
No, I couldn't agree more. And perhaps also, really ensuring that there's a connection between the patient and the healthcare professional, right? And you mentioned some of the kind of access and institutional barriers, and that's, half the battle. They have to be able to get that access to the right person. But then also once they're in front of the physician, they need to feel, like you said, empowered to be able to describe their symptoms, to explain that, everything is not normal, and to be able to get appropriate care, of course, as well as appropriate follow-up. So, and this is really something that we are passionate about, because I think really the focus of today is about what tools can be put forward to help with this, right? So, of course, we're having a discussion today, but if you were to pick your sort of top three things that we can actually do today in healthcare to ensure that women have access to healthcare, that they're being treated in an appropriate way. Where should we start? And maybe Fatima, would start with you because you're currently practicing, in the healthcare world.
Yeah, and I'll say it's hard to say just three things, but I think the a very important one is access, right? And we hear this over and over again. So if you have abnormal symptoms, if you're concerned, is it easy to come see us in cardiology or in even probably more upstream in primary care? The answer is no. So we have an access issue. I think the second thing is we have great evidence in cardiology for things that work. So we need to close gaps in things that we know work. They're cost effective, they're efficient, and for whatever reason, we have really not made any strides in this. And I don't think we need new advances in technology. I think we have to use the existing things we have now, get them implemented, really focus on implementation. And the final thing is to really, again, move upstream and start early. So start before people get to the hospital. So this is really moving interventions outside of our healthcare system. We know that social determinants of health are a very little bit of it is healthcare. So can we move to the communities? Can we make life healthier so that we don't have people needing to get healthcare?
Yeah, and you mentioned some of the kind of advancements in technology and in the innovations. And I wanted to sort of, end on a positive note with looking into the future. So, what are some of the advancements that you see today or that are perhaps on the horizon that you're excited about, whether it's technology, whether it's the way we're providing care, whether it's more, use of appropriate, telemedicine where it makes sense, appropriate use of, like you said, implementation of new technologies. What are some of the advancements that you really think are going to change the way that we treat patients in cardiology, whether they're, women or men? Maybe I'll start with you here again.
Yeah, so I'm really excited about this as an area of investigation for me is the use of artificial intelligence. And again, I consider artificial intelligence not just like a cool gadget that we're just going to throw it in and it's going to discover things, but it's a tool. I think we have scientists and clinicians asking questions, can we do things quicker, more efficiently? One example in our world is can we identify coronary calcium or atherosclerosis and other vasculatures? Again, identifying people when they already have the information in their medical records. Very good use of artificial intelligence. I am really excited about that large language models. And again, using that appropriately to change care. And then you're right, access in terms of telemedicine. I see about half my patients through telemedicine who live very, very far away from Stanford, who for whatever their life circumstances is very challenging to get to a tertiary care place. So the appropriate use of telemedicine for outreach, again, with the guardrails that are necessary to make sure we have the care that they need afterwards is a great advancement. And I think we're not going to go back in not using it after the COVID pandemic.
And I think this is really important for women because as we mentioned earlier, many women care. Exactly. So if you can't get childcare today, you can't go to your appointment. But if you can sit in front of your computer for half an hour, it's going to give you that access. So couldn't agree more. And what about you, Joanne? From the perspective of both, cardiology, healthcare, advances in the pharmaceutical industry, what are you excited about?
Yeah, so absolutely. I think Fatima and I are like-minded in the ability of technologies to really change how we receive and deliver care. I think within the pharmaceutical industry, I think I'm particularly excited about efforts to really merge technology, data, and therapies to really hopefully achieve personalized care, and ensure that for patients, we're really providing them the right therapy at the right time, given their risk profile. We have so many tools in our armamentarium to improve health, but what we really need to do now is focus on ensuring that we have personalized precision medicine for individuals that really gives them the best outcome. And I think the more that we can do that and leverage all the technologies we have, the greater chance then we'll have to address unique risks in individuals, and ultimately address, better health trajectories for folks.
Yeah, and I think it's sort of a perfect merge, and perhaps even with artificial intelligence, because I was just reading an article about a big study going on in Europe and globally in heart failure, where there's actually an artificial intelligence engine being developed to personalized care for patients with heart failure. And it's going to be, I think, a 4 or 5 year study. So, a perfect merge of really personalizing treatment in cardiology and some of the technological advancements that we've made. And I think it's been a great discussion today, and I want to thank both of you for joining. I have one very last quick question for both of you, and that is, what do you think the future, and it's a really hard one, but what do you think the future will look like, in 10, 20 years for women who are entering the field of cardiology?
I think it's a very exciting time to enter cardiology. I always tell people that you'll never be bored in cardiology. Every day looks different. There's always a new advancement. And I think what's really great about cardiology is that we have great treatments and we can really make a dent, make people feel better, or improve prognosis. And that's what medicine is all about. I hope that when I go to meetings like ESC and the American Heart Association, everybody on stage is a woman. So I think it's happening. The transition is happening, and I'm hoping that we can get to parity with, again, women in leadership. We've seen how effective this is, and I'm sure we're heading in that direction, especially with leaders like Joanne at the helm.
And I would just echo, cardiovascular medicine still has so much opportunity to help individuals given the enormous burden and impact of the disease, that the future is bright. We see more and more therapies being developed. But in some respects, my hope for the future is a world where we're not talking about quote unquote women's issues or diversity and inclusion as mandated, but that we've really moved to a society and healthcare system in which equity is embedded and health outcomes are equitable for all. So no one will be thinking about, is this a mantle? Do we have appropriate women on the stage? It will be achieved. And hopefully that, these aren't women's issues. These are human issues in ensuring that all can reap the benefits of our scientific and medical accomplishments. And all leaders need to tackle this. The stage is set, I think, to some degree for all leaders to be successful in ensuring health equity. I think the challenge now is that we have to really lean into this future state with conviction, and that this is everyone's job, right? This isn't, as I see it, a woman's issue. This is our issue as a community, a global community trying to address health.
And I think that's all of our common goal. So with having said that, I want to thank both of you for joining me today. It was a really great discussion. And for everybody listening, please stay tuned for the next episode of our Women in Healthcare Leadership series. Thank you, everybody.
Thanks for joining us. Tune in next week as we continue our journey to amplify the voices of women leaders in pharma and medicine. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next week, remember to lift as you rise.